Assalamu alaikum wa rahmatullah. You can see that I'm happy because it's the DDH lecture. This subject I've been working on for the past about like 10 years approximately. It's really my interest in pediatric orthopedics. I hope it's going to be a fruitful lecture. So we will be talking about developmental dysplasia of the hip. For sure, the next lecture is going to be about pediatric hip disorders, but DDH is one of the pediatric hip disorders, but it's separated because it's very important and common. So to start with, we will be learning in this lecture what is DDH, why DDH, how to diagnose and treat, the cost of treatment, and finally with the take-home messages. Orthopedics, as you can see from the past 13, 14 lectures, is about biomechanics. So it's biology and mechanics. So we in orthopedics, as you've seen that, how the patient fell down, exactly, did he have rotation, anyone in the car did, if there's a broken glass, if the car flipped, what was the speed, how's the transmission. So we just keep asking questions about the mechanism of injury. We are predicting injuries. So in the biomechanics, we really care for the patients, how they walk, the gait, the running, everything. So it's all about really biomechanics. So DDH is developmental dysplasia of the hip. So we're talking about the hip joint. Again and again, hip is a ball and socket. It's giving you a wide range of motion. The more range of motion you get from the joint, the less stability. So it's composed from two parts, which is the acetabulum and the head of femur. So the acetabulum is composed from three bones. So this is the pelvis, as you can see. This is the acetabulum. So it's composed, or the articulation of three bones, the three innominate bones, which are the pubis, ischium, and ilium. So three of these bones are meeting inside the acetabulum. And whenever two bones or three bones meet, they meet in a cartilage. It's very important to remember always this name of the tri-radiate cartilage. Why it's tri? Because from three bones, so it's tri. Radiate is like the radiation, so it's called tri-radiate cartilage. So it's coming from three bones, the three innominate bones. It's in the acetabulum. So the reference for you, whenever you want to see the acetabulum in the pediatric age groups, you look for the tri-radiate cartilage. Okay, the other part of the hip joint is the head of femur. So the head of femur, you can see that this is the head, the neck, the greater lesser trochanter or the trochanteric region, and the shaft. The head of femur, there is a depression here, the small depression, it's called the fovea, and you have there the ligamentum teres. So this is the bony part that we talked about. As you all know, around any joint, there is like ligaments. You have the extracapsular ligament and the intracapsular ligament. The extracapsular ligament, which is outside the capsule, so they are not inside the capsule. There is no synovial fluid within them. So basically, there is in the anterior and posterior part, we have the iliofemoral, pubifemoral, and the ischiofemoral. The most important one is the iliofemoral. And inside the intracapsular ligament in the fovea, as you can see in this picture, we have the ligamentum teres. Now we have something called the labrum. The labrum is a fibrocartilage. As you can see, it's covering, it's around the acetabulum. It makes it more deep. Okay, more deep, so more stable, and it keeps the intra-articular pressure, the negative pressure, so it gives stability to the joint. And as you can see in this video, you can see the difference. This is the labrum, as you can see in here. So he's trying to dislocate, but it's not dislocating. Listen for the voice. He removed the labrum, as you can see here, and after he removed the labrum, it's easily going in and out. Repairing of the labrum, again, it's stable. You can hear the sucking effect of the negative pressure. So the labrum is very important. So why DDH? DDH, the incidence of Jordan, is 13 per 1,000, which is very common in the pediatric age group. Each year, approximately, we have about 223,000 newborns. So by doing the math, it's about like 3,000 cases per year. The problem is that it's 8 cases per year, and there is approximately half of them either missed or mistreated. So they are either missed or mistreated. So this is the incidence of DDH in comparison between Jordan and other places in the world. It's really common in the Mediterranean region. It's really common. So orthopedics means it's orthos, which is orthosis, which is to be straight, and PD, which is pediatrics. So it's orthos PD. And this is the gait of a kid who's 1 year old. And as you can see in all of the phases of the gait, the patient or the kid is trying to keep both of his limbs on the ground because he cannot do one stance gait. He cannot stand on one limb. He can't jump on one limb. That's why he's moving very fast. He can't be standing on one limb alone at this age. But when he becomes 7 years old, he's exhibiting the mature gait. And if you can take this picture or this kid and make the picture bigger, you can see that his left leg is off the ground. This means that his weight is going through the right leg. So it's going by nature through its right hip joint. And as you know, in Newton law, whenever you're pushing a subject, it will push you back, okay? So pushing back of the ground, it will go through the leg to the hip joint. So the hip joint is holding your weight each step you're moving. Torque, let's talk about torque. So torque, basically, when you want to move or to do rotation, and you have the center of rotation in here, and this is the lever arm, okay? So what you do usually, you go from the most distal, the most far point, and you do the rotation because it will be easier for you. So let's take an example here. So if I want to do rotation on this femur, if I'm holding it from near the center of rotation, which is the head of femur now, I'm trying to do rotation, I need more force. Whenever I go further more, whenever I go away from the center of rotation, whenever I go away from the center of rotation, the movement will be much easier. Why? Because the torque means the distance multiplied by the force. So the more the distance, the more power is produced. So again, the fulcrum, it's the same. Whenever you make the lever arm more long, you need less force to do rotation. What has this to do with the hip? This is a normal hip X-ray, a right hip X-ray for pediatric age group. You can see here the epiphyseal line, here the epiphyseal line. You can see the triradiate cartilage in here, which is the reference for the acetabulum. This is the head, this is the neck, this is the greater trochanter or the shoulder. This is the femoral neck shaft angle. And if you look at the femur itself, you can see that there is a femoral neck shaft angle, which is normally in the adults, it's 125 plus minus 7. In the pediatric age group, it can be 160 when they get born and then start to get down. The center of rotation that we will be talking about now is the head of femur. And I will show you here the model to demonstrate what's happening. So basically this kid, as you can see in this picture, that he's standing on his right limb. So this is the right limb and the patient is moving exactly, it's holding him like this. So the force that is affecting this pelvis is the weight. So what's gonna happen? The weight is medial. The weight is medial. So what's gonna happen? That the pelvis will tilt. The pelvis will tilt. But normally when you stand on one limb, you don't have a pelvis tilt. Why? Because there is muscles are working on the other way around. So standing on one limb, the pelvis, you have weight here in the middle, medially. So what's gonna happen? The pelvis will rotate. This rotation, what is it called? Adduction, it's adduction. So if I'm doing this to the pelvis, or I'm doing this to the leg, it's the same. It's the same. So what's happening when the pelvis is trying to go down, what's happening is adduction. So the group of muscles that should work, the abductors, the AB, the abductors. So the abductors work and they stabilize the pelvis. So they bring the pelvis from its origin to the insertion. The origin is from the iliac wing to the greater trochanter. So they bring the origin to insertion. So the pelvis is stable now. Okay. So when you're standing on one limb, what's happening? That the weight is going medially, the pelvis will be rotating. The abductors, on the other hand, will work, so they will do a contralateral side, or they will do a force that is against the weight, so it will hold you. I hope it's clear. It's very important to understand this point. So normally, as you can see, the head of femur is inside the acetabulum and there is a very good coverage. So the thing is, the head of femur, the acetabulum, it's covered. This is the most important thing. And as you can see in this picture, this is the acetabulum, okay? What is this? What is this cartilage? It is the triradiate cartilage. This is our reference to the acetabulum. It's very important to keep this in mind, triradiate cartilage. So the upper part of the acetabulum, this part you can see in here, it is called, it is called the acetabular roof, the acetabular roof. And the acetabular roof is very important because it is the weight bearing area of the acetabulum, because your weight is pushing down and the earth is pushing up. So the femur will hit the acetabular roof. Okay. Normally when the head is inside the acetabulum, your weight is distributed on the acetabular roof, on the red mark in here. So your weight will be distributed here. Now the problem of the DDH, the developmental dysplasia of the hip, the problem, it's not just dislocation. So what's happening, there are stages of this disease. The first stage, it's having a shallow acetabulum, which is called dysplasia. So what's a shallow acetabulum? So as you can see here, this is you having now here the femoral head. This is good coverage. So what's happening in the DDH, the first stage is that the coverage of the acetabulum is opening a little bit. You can see it was like this, now it's like this, it's open. The more it opens, the more it opens, the more it opens, now the head starts to be lax, going out and in, which is called subluxation. And when it's having a lot of dysplasia, there will be dislocation. Now it's dislocated. So all of the patients, they are going through this path. Normal, start to having dysplasia, more dysplasia, subluxation, dislocation, and high dislocation. So in the dysplasia, in these early stages of DDH, what's happening that the head is going outside a little bit. It is still inside, but it's going outside a little bit and it's dysplastic. So look at the acetabular roof space. It's getting less and less and less. Same weight on less area, the force will be high. And the more dysplasia is gonna happen, the less the area, or the smaller the area that's your weight pushing on the acetabular roof. The more force you are having, the more force means that the cartilage cannot hold that weight, so it will be degenerating and it will cause you secondary osteoarthritis. So this is one of the complications of DDH. The more dysplasia you have, the more osteoarthritis you might get. So this is the first thing. As you know, that patients who are having bilateral DDH, bilateral dislocated hips, they are walking with waddling gait. Why? Let's get back to the models. So basically, you remember this guy who's standing on his right limb? Yes. So when the pelvis is going down, so what's happening? The abductors work. Okay. But the problem when the head is dislocated in the DDH, there is dislocation in here. Look at the origin and the insertion, the iliac wing and the insertion, the greater trochanter of the abductors. When you have a posterior dislocation, they are getting closer. They are getting closer. Whenever you bring the insertion to the origin for any muscle, it will get weaker. So the problem with the DDH, when they have a dislocation bilateral, they have bilateral weak abductors. So when they have bilateral weak abductors, they cannot abduct. So they cannot stabilize the pelvis. So what to do? These patients will be falling whenever they want to walk. So what are they doing not to fall? This is smart. Let's get back to the torque. You remember the torque? When I want to do rotation, I go further more. And whenever I get closer, it will be more force. And whenever I get closer, it will be more force. Whenever I get closer, more force. What if the force was directly to the center of rotation? It will rotate? Never, because the distance from the center of rotation is zero. So whenever you multiply anything by zero, it's zero. There is no rotation. So if I don't want to have any rotation in the femoral head, I put the force on it instead of the femur. For example, I want to do rotation like this. No, just put it in the center of rotation, pushing and pushing and pushing. There will be no rotation. But when I put it like here, now it's moving. So this is what the patients are doing. They move their upper body, to the side they are standing on. So basically what's happening, this is the center of rotation, this is the hip. It's like this. So the upper body, the patients are moving like this. They are leaning toward the hip they are standing on. So the axis of their body, the weight, because it's moving in the medial aspect, as we said, it will be moved to the center of rotation. So the weight will be directly to the hips. That's why when they are standing on the right side, they will move to the right side. Okay, so all of the weight is going to the center of rotation. So there is no need for the abductors now to work. That's why the patients who are having DDH, they will work when they stand on the right side, they will go to the right. And when they stand to the left side, they will go to the left. This is called waddling gait. Waddling gait, like a penguin, for example. But if the patient's having unilateral, only one side, for example, let's say it's only the right side, the left side is normal, they will be walking like this. When they stand on the right, they will be tilting to the right, moving the center of rotation to the head of femur. Then they will get back normally, do the step to the left without leaning forward, then leaning to the right with the right side. So this is called Trendelenburg gait. Trendelenburg gait. So it's waddling gait for bilateral and Trendelenburg for the unilateral. I hope it's clear. Okay. Waddling gait.
Sì, cammino aquí. Bueno.
Okay. They used to say that this disease, it's called congenital dislocation of the hip, which is CDH. So is it CDH, congenital dislocation of the hip, or is it DDH? Let's go a bit for the growth and development. And as you can see here in the 5th week, there is the upper and lower butts, they start to go on. On the 7th week, we have the mesenchymal cells, which is the primitive limb bud. And as you can see here, you can see this is the femoral head, this is the acetabulum, and the femoral head is inside the acetabulum. They continued this study, and at the 12th week, they saw that the precartilaginous cells, they are fully formed femoral head and acetabulum, and the femoral head is inside the acetabulum. That's why the difference between a congenital and developmental disease, what's the difference? What's a congenital disease? The most important part of the congenital disease is the problem during organogenesis. It's a problem during organogenesis, like ventricular septal defects, atrial septal defects, spina bifida, cleft lip and palate. All of these are congenital diseases. So there were problems during organogenesis. In the developmental dysplasia of the hip were created normally. The head of femur was inside the acetabulum, but then external forces happened and made the femur dislocate. Let's get another example. Hydronephrosis in the pediatric age group, when they had a kid, a fetus who was born, and they found that he's having hydronephrosis, they were thinking that, this is congenital. But after having the ultrasound, sometimes they were seeing that there is a stricture in the urethra. So because of this stricture, the kidney was normal. Then the kidney started to produce urine. The urine started to get down to the ureter. More pressure, because it's closed. So the problem in the ureter, not in the kidney. So the kidney started to get more size. So it's now hydronephrosis. So it's now developmental, it's not congenital. There are some cases who are having congenital, but when you have a problem in the other part, it's not in the kidney, so it's developmental. So it's the same thing for the DDH. So the head of femur was inside the acetabulum, it's called developmental dysplasia of the hip. Is there congenital dislocation of the hip? Yes, if they have another deformities. And in pediatrics, there are a lot of congenital deformities who are coming as a part of a syndrome or something like Bactrials or so on. Okay, let's make it more simple. Head, neck, and shoulder. Head, neck, and greater trochanter. Hat, or it's the acetabulum. So what we need to see that this man with the hat and covering the head in a normal shape. But what's happening sometimes that you have a normal head, but it's a very small hat, very small acetabulum. And sometimes you have a normal head, but the acetabulum is very big. Sometimes the head and the acetabulum are okay, but it's tilted, as you can see, which is coxa-vara and coxa-valga that we will be talking about in the pediatric hip disorders. Again and again, DDH is not dislocation only. It has a wide spectrum of the pathology that you have dysplasia, subluxation, dislocation, and high dislocation. This is very important. This is very important. Reduced femoral head is the largest determinant of acetabular development. So whenever you see a dislocated hip, please relocate the hip. It is time to put the hip back inside. If the head is inside the acetabulum, they both will grow normally. It will be moving the head, everything will be fine. If the head is dislocated, the acetabulum will be shallow, and the head of femur, there will be no use of it. That's why whenever you see a dislocated hip, reduce it immediately. Femoral head vascularity is very important too. You know that the medial circumflex femoral artery is coming around the neck, and it gives the retinacular arteries, as you can see in this picture. The retinacular arteries are like the carotids for the head. How the head is getting its supply? It's from the carotids. So here the retinacular arteries are giving the blood supply to the head. It's very important to keep this in mind because we will talk about some of the complications for treatment. There is a small branch, it's called the acetabular branch, part of the obturator artery. It's very small, and in the adults, it's gone. Very important to know the risk factors. That's when we want to do screening, we should be sometimes selective because it's costly to do screening for everyone. So what are the risk factors? Breech presentation, and it's the frank breech. In this picture, it's a complete breech, but frank breech, it's a well-known risk factor. Ligamentous hyperlaxity and a female. You know that the incidence of DDH for females to male ratio is 7 to 1. 7 to 1. Why? Because in the third trimester, the mother will produce a hormone by the placenta, which is called the relaxin. The relaxin will relax the ligaments, the pelvic floor muscles. It's preparing the mother for delivery. So what's happening to the mom is happening to the female because she's having the receptors. In the males, they don't have receptors to have hyperlaxity. That's why it's more common in the females. Family history for sure and ethnic backgrounds. Firstborn, which is primi gravida, the first baby. Oligohydramnios, which is the amniotic fluid around the fetus, is going less. Both of these, they are telling you that the uterus is still tight. There is external forces are pushing on the femur, so it will make it dislocate. So all of these, as you can see, they will give you a hint that this is developmental disease. It's not congenital. Packing syndrome, they say left hip is more commonly dislocated than the right. Extreme positions during labor, which is traumatic DDH. And the most important one of these is the postnatal care. All of these were non-modifiable risk factors, but the postnatal care is a modifiable risk factor. We have this thing in our countries in the Mediterranean region, which is called swaddling. The patient or the fetus in the fetal life, flexion of every single joint is flexion from the fingers, the hand, the elbows, the head, is flexed. So when he's getting born, and especially in the winter time, the mother wants to make him warm. So what's happening? She put him in severe extension position and she strapped him. So swaddling increases the risk of DDH. Be careful. Okay, let's go for the diagnosis. Now for diagnosis, like any other disease, history, physical examination, investigation. We're done with the history and the risk factors. Now for the diagnosis. In the diagnosis, we have two tests. We have the click and the clunk. Click and the clunk, both of these tests. Let's start with the clunk. We have ortolani. It's a test that you relocate a dislocated hip. So what's ortolani? You are relocating a dislocated hip. So let's show you on this model. So what's happening? This is ortolani. It's a dislocated hip. You do flexion, abduction. What's happening? The hip is going inside. You feel with your hand that the head is going inside. You feel the clunk, which is called ortolani. And this is a video that
now we talked about the hips and risk factors, and now I'm going.
Okay, this is a video that will show you how this doctor is examining this kid, that he's trying to do relocation of a dislocating hip without using much force, So you're putting your fingers on the greater trochanter, you do abduction, you are trying to relocate the hips inside, you are trying to feel the clunk. Now we have Barlow. Barlow is an axial load, axial force. You are trying to dislocate the hip. It's an assessment of the ligaments, assessment of the position of the hips. So you are doing Barlow, then you are doing ortolani again. Sometimes
Now I'm going to be a disciple of old Barlow.
Sometimes you don't have to do Barlow like very with powerful, because you will dislocate the hip because you are treating pediatrics. So you are assessing the ligaments. You do have to be gentle during examination while doing Barlow and doing ortolani. So Barlow, you are putting axial pressure. You are trying to see that the hip is dislocatable or not. Then you are doing ortolani again. So this is ortolani and Barlow, very important examination. Asymmetrical skin folds, as you can see here, because the femur is the same length, and when it's dislocated posteriorly, it's going back. So the skin above it, it will be having creases. So here on the right side and left side, here we have one more skin crease. So most probably on the right side is the DDH. Not every pediatric have a skin crease is having DDH, but is an indication. Late sign is called Giliazzi. What's Giliazzi test? Flexion hip, flexion knees, and you can see difference in the length of both of the limbs. It's an apparent difference. It's not true because the hip is dislocated. When you relocate the hip, the length will be okay. Adduction contracture, because the hip is located posteriorly, the hip will be adducted. As you remember in the trauma, when you have a posterior hip dislocation, you will have an adduction of the patient. So when the patient is having adduction and he can't do abduction for a long time, he will have adductor contracture. And these are one of the important parts that you have to treat when you do reduction. You do reduction by abduction as ortolani. What if the adductors are tight? That's why sometimes we go in and we cut these tendons, which is called adductor tenotomy. We do tenotomies so we can have the reduction going easier. Important, very important, very important, very important. Please never, ever rely on physical examination only, to diagnose DDH. Don't just examine the kid with your hands and you reassure the patient, oh, everything's fine. No, because in the early stages, which is dysplasia, as I told you, when you do abduction, when you do flexion, when you ortolani, Barlow, you will feel nothing because the head is inside. There is dysplasia, but you can't reassure the patient. We have a lot of stories. We have a lot of patients who are coming late to the clinic and they told us, the doctor, when we had this baby, examined him, but how can you tell us now that he's having dislocated hips? It's very important not to rely only on physical examination. Please don't do this mistake. Okay, this is for the physical examination. Now we'll go for the radiological. The gold standard for these patients below 3 months is to go for ultrasound. Why ultrasound? Because as you know, the patient or the kid still having cartilage is not well ossified. There is no calcium. It's not radio opaque yet. That's why when you do an X-ray, you will find nothing. You will find nothing. And the advantages of the ultrasound that it's portable, it's affordable, there is no radiation, but the only problem with the ultrasound, which is major one, basically, it is operator dependent. It depends on the one who's doing the ultrasound. There is a lot of markers you have to see. Graf, he's from Austria. Dr. Graf is from Austria. He's the one who invented the ultrasound for DDH. And it's not easy. It's not hard, but you have to have practice to do the ultrasound for kids. So it's operator dependent. That's why this is the only advantage of the ultrasound. So just to have an idea about the ultrasound. So basically this is, as you can see on the left side, you can see this is the head, the neck, the greater trochanter, and the shaft. This is the iliac wing, this is the acetabular roof, and this is the labrum. On the other way, in the right side, you can see the same. This is the acetabular, this is the iliac wing. This is the acetabular roof, this is the labrum, and this is the femoral head. And these are the fat tissue on the lateral aspect. So basically what's happening, Graf, what he did, he had the lines, he had 3 lines. He had one line through the iliac crest, one line through the acetabular roof, and one line through the labrum. And he had an alpha and beta angle. So he calculates alpha and beta angle. And as we can see here, if the alpha angle is going less or going smaller, it's worse because the head is going laterally. And when the beta angle is going big, it is worse. So when beta going down, alpha is going up, it's better because the head is going inside the acetabulum. And these are graph type 1 and type 4, depending on this graph, on this table. So this table will show you the angles and how or what to do for these patients. So we rely on ultrasound to diagnose and treat and follow up these patients. X-rays. Should we do an X-ray? If you do an X-ray, it should be after 3 months, okay? It should be a pelvis AP lateral X-ray because the ossification nucleus, you can see it and you can see that there is well-defined margins and edges that you can draw on. So basically, this is an X-ray for an old guy, 30s, 40s, so whatever. It's very important to know that this 3D object, that the pelvis that you want to shoot, this is a 3D object. You want to do an X-ray, it will be 2D. So it's very important to take the position, not like this, inlet view, outlet, obturator, iliac. It's very important to get a AP, true AP. So let's get down with the age to see the differences. This is a kid, okay? How did we know that this is a kid? That we have the epiphyseal plate here, epiphyseal plate here, epiphyseal plate, epiphyseal plate. What's this? Let's go back to the adult. There is nothing in the acetabulum here, which is bilateral in here. What is this? Triradiate cartilage, which is the reference for our acetabulum. Okay, let's go down with the age to 4-6 months. Let's see the difference. Look here. Now you can see that this is called the ossification center. That does not mean that this black area is empty. No, it's normal. He's having a normal femur, but it's still cartilage. So if you open a surgery and you look at the femur, you will see a normal femur like yours. But on the X-ray, you can't see it because it's not yet calcified. So you can see here the ossification center. You can see here the triradiate cartilage. How wide is it? Look at here. Look at the puderator foramen and the lower aspect, the ischium. Okay, you can see that the inferior pubic rami, that it's not seen. Why? Because it's cartilage. Okay, so this is the picture that we will be working about. The first thing to do when you see X-ray patient profile, for whom is this picture? When it was taken, very important. What is the type of the investigation? So this is a X-ray for Chris. He's 4 months old. This is an X-ray showing the pelvis, an AP pelvis X-ray, okay, showing the pelvis, the proximal femurs, and the lower spine. So basically, we will comment on the most important things for DDH. The first thing to do, what's the view? It is AP. But is it true AP or not? What's true AP? You have to make sure that there is no tilting or rotation. How to know? We look at the level of the iliac wings, level of the triradiate cartilage, and the ischium, okay? So by this, we know that there is no tilting. What about the rotation? Look for symmetry. So we look at this iliac wing and the other one. If I'm talking fast, you can pause the video and go back slowly. Okay, so on the right side, you can see that this ilium is approximately the same size. Approximately is the same size, not with like a ruler. You have to make sure that this is 32 centimeters and a half. No, it's just like approximately the same. The obturator foramens, the same. So this means that this X-ray is AP with no rotation, which is acceptable. Okay, now the first thing to diagnose DDH on X-ray, we have to draw lines which are called the reference lines. The first line is called H line, the Hilgen-Reiner's line, which is a line that's between the two triradiate cartilage. You can see here on the right side that there is upper border of the triradiate cartilage. On the left side, the same, upper border and lower border. So usually we draw on the upper border. Why? Because we are caring about the acetabular roof, which is the weight-bearing area of the acetabulum, okay? So upper border, we draw a line which is horizontal, which is called Hilgen-Reiner's line. Hilgen-Reiner's line. This is the H line. Now we have another line which is called the P line. What's the P line? It's the line perpendicular to the H line. It is the most lateral part of the acetabular roof, which is going perpendicular to the H line. So this is the acetabulum, because this is the triradiate cartilage. This is the acetabulum. So I will draw for you so I may make things easy. Okay. So basically, okay. So this is the acetabulum, okay? This is the acetabulum. And this is the acetabular roof, because it's the upper part of the acetabulum. This is the lower part of the acetabulum. We don't care about it now. So we need only this part, which is the acetabular roof, okay? The acetabular roof. So we go for the most lateral part of the whole acetabular roof, which is this point. This point, okay? This is the most lateral part. And what will happen, that when we press next, you will see that the most lateral part is going perpendicular to the H line, okay? Let's take the other part. Now, to draw on the dislocated part, we have to understand the thing that you can see on the normal side, let's go back to the normal side, that the acetabulum, it's a sphere, hemisphere, it's a 3D object. When you look at it by X-ray, you can see that it's 2D object. So I'm gonna show you this model. So in the model here, you can see that we have the anterior part and the posterior part of the pelvis, of the acetabulum. This is the anterior part and this is the posterior part. So the anterior part is called the anterior lip, posterior part is called the posterior lip. How can we see this on the X-ray? Okay. How can we see this on the X-ray? Okay. I'm trying to make this work. Okay, so how can we make this thing? Sorry for the delay. Let's clear everything, then draw again. Okay, so on the right normal side, you can see that this anterior lip, look at it, it's the hypersclerosis, the white thing you can see. This is the anterior lip, and this is the posterior lip. So you can imagine that it's a hemisphere. You can see that it's a hemisphere. So this is the anterior lip, and this is the posterior lip. Okay, let's go and draw the anterior and posterior lip on the normal side. Okay, so on the normal side, as you can see, okay, let's clear everything again. Okay, and take the mouse. As you can see here, this is the anterior lip. It's going up, 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 up because it's dysplastic, and this is the posterior lip, okay? So we take the most lateral part of the whole acetabulum. P line, we take the most lateral part of the whole acetabulum, not the anterior or the posterior lip, okay? So H line, 2 triradiate cartilage. P line, most lateral part of the whole acetabular roof. Very important. Okay, now we know how to draw the reference lines. What's next? The most important part in the diagnosis of the DDH is the acetabular index. What's the acetabular index? This is the femoral head. This is the acetabulum. The more the acetabular index is going up, for example, if this is 30, 40, 50, 60, more dislocation is happening. So the less the angle, the better. So for example, at the age of 3 months, 4 months, we like to see the X-ray, the angles about 28, okay, about 28. So if you see it like 40, this is bad because it's gonna be more dysplastic and more dislocation. So the first line you will draw, okay, when you want to draw the acetabular index is, you already draw the first point, which is the acetabulum when it's crossing the H line. So this is the H line. This is the acetabulum. Okay, they crossed in here. So this is the first point. So this is the first point. So we now have the first point, which is this point, H line crossing the acetabulum. And the other point, here we should care about the lips. The most lateral part of the anterior lip. It's not the posterior lip. We are caring about the anterior lip. So this is the anterior lip, this is the anterior lip, the sclerosis you can see here, here, it's done in here. This is the posterior lip, okay? So we draw on the anterior lip. If you forgot, draw on the anterior and the posterior and take the bigger one. So let's see how it will be, the acetabular index. It's gonna be like this. So this is the acetabular index for the right side. For the left side, the first point is the acetabular when it crosses the H line, which is this point. Oh, sorry, no. So the first point that we will draw is the H line crossing the P line, which is this line. And this is the anterior lip. This is the anterior lip. It's going up like this. And this is the posterior. So we should draw on the anterior lip. So let's see how it will be. Okay, it's like this. So on the right side, we calculate it. On the left side, we calculate it, okay? So this is the acetabular index. This is the acetabular index. For me, on the right side is 23, on the left side is 55, which is very dysplastic for sure. It must be less than 28. The second line, so this is for the acetabular index. The second line, it's called Shenton's line, which is the medial aspect of the femoral neck along with the inferior border of the superior pubic rami. This is the superior pubic rami, inferior pubic rami. So it should be a line which is not disrupted. So here, medial aspect femoral neck with the inferior border of the superior pubic rami. Here, medial aspect of the femoral neck with the inferior border of the superior pubic rami. You can see how much it is disrupted. So on the right side, you can see it's a smooth, nice line. On the left side, it is very disrupted. It's very disrupted, okay? So now we know the acetabular index, we know the Shenton line, and the last thing, we should look at this ossification center, the head of femur. Where is the head of femur? Normally, it should be in the inferior medial part here, in the inferior medial part. When it gets dislocated, it's going to the lateral, then it will be high dislocation going to the superior lateral quadrant. So we look at the ossification center and we say it's an inferior medial quadrant, in the inferior lateral, or in the superior lateral, depends on the position. There are a lot of other signs we will not talk about because these are the three most important for you. Centered angle or the inverted Shenton line and so whatever. You don't have to worry about them. Just you have to know the acetabular index, the Shenton line, and the ossification center on the X-ray. I hope everything is fine. Okay, now it's gonna be drawn again. Okay, acetabular index less than 28 at 3 to 4 months. And when you go bigger, the angle is going down because you're getting older. So whenever the kid is older, we don't accept 28 at 1 year, for example. Shenton's line, it has to be not disrupted and ossification center. A lot of cases of DDH, a lot of cases. This is a 3D reconstruction showing you the posterior dislocation of the hip. Arthrography is sometimes really important. It's very nice. What's the role of arthrography? We put dye inside the joint and we can see the cartilaginous part by X-ray because there is dye inside the synovial fluid. So it will help us to see that our reduction when we do is concentric or not. Is our reduction is going the head inside, or there is something inside is not letting us to reduce the hip. So sometimes arthrogram is mandatory to do. You can do CT MRI. Treatment. What to do in the treatment? The treatment is as simple as that. You have the hat and the head. What you will do is to bring back the hat to the normal position and to get a normal head that is covered. So the treatment, you remember ortolani, we do ortolani and we fix. So all of the stents you will see, the von Rosen, the Frigid Capello, and so whatever the Pavlik harness, all of them are doing abduction to relocate the hip inside. Pavlik harness now, it's the gold standard for treatment of DDH below 6 months. It's a dynamic, it's a nice, really tool we use in orthopedics. It's good, it's the best in the market usually. It has a lot of complications for sure. Anything have a lot of complication, but the least complication. It may get you a vascular necrosis, it might kill the head. It might give you Pavlik harness syndrome, which is femoral nerve palsy, and so whatever. So what about the diapers? Should we put diapers for our kids? Well, that's a problem nowadays. The problem is before like 20, 30 years, they used to have diapers like towels. So these towels, they have to use triple diapers and they were putting them and they were doing abduction. So it's like you are putting um, a spike or a splint for the kid. The problem is not with these diapers, with today's diapers. Today's diapers, as you all know, is active baby and dry baby, and they are moving very easily. So when you put 1, 2, 3, 4 diapers, the patient is moving normally. So the problem, the family are paying more money, they are getting more of these diapers, but the problem, nothing is happening. You are just masking the problem. So please don't advise the patients to put triple or double diapers as a treatment or prevention of DDH. If you want to treat, just go for the gold standard for treatment, which is pelvic harness, hip spike, abduction splint, so whatever, okay? When the patient is getting older now, he's starting to sit, the hip spica, the abduction, the pelvic harness is working by gravity, the patient playing, and when he's done, his legs are going by abduction. So what's happening that when he starts to sit down, there is no gravity. So that's why we have to go for a fixed or rigid fixation, which is Craig's splint or abduction splint. The problem, we are going from dynamic to static. Static means we are putting more pressure and sometimes we can cause avascular necrosis. Galloextraction is no more used anymore. They used to have them long time ago. Hip spica. Hip spica after 6, 7, 8 months now, it's the gold standard. Why? Because the patient, as you can see in the picture, he's under anesthesia. We reduce the hip, we make sure that the hip is inside. Sometimes we do additives, which is, I told you, tenotomy of the adductors. We might do arthrogram. We reduce the hip, we make sure 100% that our hip sits inside, and we put spica. We put cast. So, and we leave the cast for approximately 3 months, depending on the case, of the age, and each DDH patient is special, specific case. Like, this is a video just to show you that the spike is not a very nice thing to have. It's sometimes devastating for the parents, because as you can see, the pediatrics are just like laughing because they just don't care. They want to have fun. So it's better to treat DDH patients as early as possible. Many ways to kill the femoral head. As I told you, the iliopsoas tendon and the medial circumflex femoral artery, they have a big problem between themselves. So they don't love each other. So what's happening when you do abduction, more and more, the iliopsoas will kill, or it will strangulate the medial circumflex femoral artery. You will kill the femoral head. So please be careful when you put spikes, pelvic harness, abduction splints, so whatever. Be careful for the head of femur not to die. So what if diagnosis delayed? What's the problem? A lot of problems. So you will be trying to reduce the hip. You remember the important slide? The head of femur had to go in the acetabulum. What if there is something sitting inside and it won't let the femoral head to go inside? Like what? As you can see here, this is the iliopsoas tendon. It's going and impinging between the femoral head and the acetabulum, and it's not going inside. And as you can see in the arthrogram in here, this is called hourglass sign. You will never be able to put back the head closely. You have to open, surgical. Adductor contracture, you have to go for tenotomy. Here, as you can see, inside the hip, there is a fat tissue, which is called pulvinar. The ligaments, look how much they are just like stretched. So when you want to reduce the hip, they will be like a ball inside the acetabulum, and you cannot put the femoral head inside. Unfortunately, it's just like the story of Cinderella. Just put the leg inside the shoe, put the head inside the acetabulum, and you will end with the nice ending story. So the problem, the diagnosis is delayed. Unfortunately, you have to go for surgery. So to go for surgery, many surgeries, open reduction, you have many osteotomies types, Salter, Pemberton, Dega, Chiari, Double, so whatever, a lot of osteotomies, a lot of cases. So for example, we have this case, you can see on the left side, the dislocated already hip. What they did an osteotomy for the pelvic side, and they retained the acetabular index again. So they did a Salter osteotomy for this patient. Another patient on the right side, you can see that this is dislocated hip another time. She was operated 3 times, and now she had 2 surgeries. She had femoral shortening, okay, and she had pelvic osteotomy. So pelvic and femoral osteotomies, both of them. So we can reduce the hip in place. So what's the outcome? What's the outcome? We really don't know. That's why the earlier you catch the patient, the better the outcome will be. The more delay, more complications. More delay, more complication. One of our cases, her name is Hiba. We presented her once on the TV. She had like 14 surgeries. This is the outcome. Osteoarthritis, she have bilateral osteoarthritis, mushroom shaped head. She has greater trochanter, like, look, very weak abductor. She's having antalgic gait. She's having waddling gait. She's in pain. What to do for this patient? We're just pushing here and pushing here and pushing here. Maybe sometimes you will be thinking, oh, why not to go and put arthroplasty? Isn't that like a nice solution? Well, it's not really a nice solution, because when you have a young adult who's like in 20s and they are complaining of pain and antalgic gait, and you want to go in and to do total hip replacement, for example, to put a total hip replacement for a DDH patient who was operated many times, it's by itself, it's really harder than normal. The prosthesis might be different. The third thing, the prosthesis can't hold the patient for like much time. So the prosthesis age, or the prosthesis is gonna be weird now, like, or later. So 5 years, 10 years, 15 years. So after 10 years, this patient is gonna be 30. She's still young. What to do? Revision surgery is like so hard. And another surgery, which is having the complications, which is having anesthesia, which is having morbidities, and so on. What if no complications happen this time? Let's do a surgery again on 40. So this is a long journey, If you want to go for hip replacement every 10 years for these patients, it's going to be really devastating for them. So the best thing to do is just catch them as early as possible and just stop all of these complications happening to them. A lot of patients we are having every now and then in the clinic, many patients are waiting for you to tell them, let's change the hips, but really this is not a solution. I'm gonna skip this video. Let's go for the cost of treatment. The cost for treatment, according to the American Academy for Orthopedic Surgery, they say if you want to treat conservative management for the DDH patient by Pavlik harness, you will cost each patient $30. So if you wanted to apply these numbers on Jordan, we were talking about 60,000, 61,000 JDs. Wow, this is too much. What if we go for surgery? If surgical with osteotomies, approximately it will cost 38,000. That was the cost of the surgery itself, the prosthesis itself, the osteotomy, the surgeon, the anesthesia, the hospital, the father that he will be leaving his work for some days, the coming and going, like the transportations and so on. They calculated just everything with the follow-ups and everything, and it will cost $38,000 per surgery, one surgery. So what if we apply this to our patients? You are talking about 77 million. And unfortunately, sometimes our patients are having 1, 2, or 3 surgeries. Sometimes it depends on the case. So I think it's really cost effective to go for these patients and screen for them and catch them early and treat them, because you will really cut the cost like so much. And it's not important to talk about the money. You will have healthy people. It's like very important that you will not have just physically injured patient, because these patients really have psychological issues. So we have to think about. So the only question that we have left is, what's the best treatment for DDH? Is the earlier diagnosis, not early, the earlier. 2 days is better than 1 week. 1 week is better than a month. 1 month better than 3. 3 better than 6. And whenever it's early, it's better. Whenever it's early, it's better. So I hope to keep in mind that prevention is better than cure. And don't forget that DH is very common. It's easily preventable. Please don't forget the ultrasound and the X-ray. And the treatment is with Pavlik harness as a gold standard. And I hope you like this lecture. See you in the next lecture about pediatric hip disorders.